because I had some computer issues this morning. That's why I'm strictly on flash drive this morning. Because I'm a licensed clinical social worker, I tell things in stories. So it gets a little bit interesting when I tell about some real stories, and stories I'm sure that many of you can tell of yourself, your friends, your family, or those patients that you serve. The first thing that we want to talk about...
Not working?
Nope. We're not going to talk. We're not going to talk yet. There we go.
We just were on it.
Oh, okay. All right. So the first thing we want to talk about here is the goal of behavioral health. There are, and this is a lot of stuff that you've already heard, some of the things that Katie said, some of the things that Dr. Anna said. This is almost going to sound like a repeat, but it doesn't hurt to do that because these are so very important things. There are 100 million Americans that have chronic pain, and very few use one of the best tools to treat it. The goal of behavioral health is to help people find the right approach to relieve their pain, to help shift the dialogue about pain relief to a more natural, more logical, and more cost-effective approach for the millions of the appropriate sufferers, and to help counter the effects of our pharmaceutical-driven culture, advertising, and medical research climate that ignores or suppresses alternative approaches. After 2 surgeries on my friend's ankle and a subsequent bout with infection, my friend followed with a short-term rehab and felt that he was okay. But soon pain settled into his ankle and it radiated up to his back, and it didn't let go. What started off as a light throbbing in his ankle quickly engulfed into his back. The discomfort then spread, producing a pain what he told me was much like hitting your ankle against a concrete wall. He was constantly rubbing it while looking for a comfortable position to prop it up for some type of relief. It's not that the pain is in their head. The truth is much more nuanced than that. All pain can have both physical and psychological components. And the psychological component is often dismissed or never acknowledged. The pain can be real pain, and it can be caused by brain circuits. What was worse with my friend was the deep sense of catastrophe that accompanied his pain. Working in a high-volume customer care organization that required a lot of physical labor for him, he depended on his back, his legs, and his foot mobility. Every time the pain got bad, he said he would think of some variation of, oh no, I'm never going to be able to do this kind of work again. I'm not going to be able to keep a job. I'm not going to be able to support my family. I'm not going to be able to earn a living ever again, and I'm going to be in excruciating pain the rest of my life. Like many patients with chronic pain, my friend sought a concrete diagnosis. For a decade, this 48-year-old strong former high school basketball star went from doctor to doctor, trying all the standard treatments, opioids. He tried cortisone injections, he tried epidural injections, exercises, even an additional elective surgery. He came to understand that his pain was not caused by anything physically wrong with him, but it was imagined, and it was real. So we have to get over this concept that either the pain is real or it's all in my head and I'm making it up. Pain can be real pain, and it can be caused by brain circuits. We have to get over that concept that I just read, that pain is all in my head and I'm just making it up. After working with a physician to wean himself off of the opioid Vicodin and feeling like he had exhausted every medical option, he and I talked, and he took a chance and met with a licensed behavioral health therapist after learning of his experience and how unsuccessful he had been trying to wean off of opioids to treat his pain, he learned from that behavioral health therapist how his pain could be purely psychological in origin. He needed to treat the true source, and that was his fearful thoughts. We've talked about that a little bit this morning. Realizing that his psychological therapy could help, he said, was one of the most profoundly surprising experiences in his life. With his experience, he said, no doctor he ever saw ever hinted that his pain might be psychogenic, meaning that his pain could be psychological in origin. The patients here at SIH are very fortunate. Few chronic pain patients ever get the chance to understand the psychological dimensions of their pain or try psychological therapies. As I said earlier, there are 100 million Americans who suffer from chronic pain, and an unknown number of them are like my friend, with back pain, ankle pain, neck pain, fibromyalgia symptoms, or other forms of pain that have no diagnosed physical cause, and their pain is not in their head. For too long, the go-to treatment for many forms of chronic pain have been opioids, and we all know that, we've all heard about it. Yet opioids have proven to not only largely be ineffective for treating most chronic pain, but also highly addictive and risky. And my friend that I was talking about got addicted to opioids, and that's been one of the hardest fights in his life. Big Pharma's aggressive marketing of pills and sometimes minimal training of doctors with pain medication means that for too long the go-to treatment for many forms of our chronic pain has been opioids. Yet we know that opioids are not totally the answer. They can help, but they're not totally our answer. So cognitive behavioral therapy. You've heard about it this morning a little bit from Katie and then a little bit more from Dr. Anna. So let's talk about it. CBT, or cognitive behavioral therapy, according to systemic reviews of research, cognitive behavioral therapy shows meaningful benefits of chronic pain, both for psychogenic pain and for pain with a physical cause. There's also promising research around mindfulness-based stress reduction and therapies inspired by it, and I know that we've all heard about it. We talked this morning a little bit about CBD. People are now more open to looking at other modalities to treat their pain. Yet many patients don't know about some of these options that exist. I know when I first came here, people were asked to SIH, people were asking me, well, what place does behavioral and mental health have in a healthcare hospital in this situation? What are you going to do for us? Over the almost 2 years that I've been here, people have come to understand what help it is to join the mind, the thoughts, with what's going on with our body, with what's going on physically. Until recently, these types of therapies have been seen as a route for no hope for the hopeless, for people who have gone through everything else and are now doing this as a last-ditch effort. As a group here at SIH and with this pain group, what we want to do is to shift that understanding of pain so that psychology is the opposite of a last resort. Pain can be manufactured in your head and in your body. We're taught by evolution and by our experience that the sensation of pain means there's something physically wrong with our bodies. This is adaptive. But sometimes a one-time injury or illness, or perhaps nothing at all, triggers years of chronic pain. And I was talking to Katie earlier because when she showed the little drawing of the foot with the nail, she and I both have had one of the same things we were going to discuss. And maybe you've all heard about this famous case study that describes the construction worker who came into the emergency room with a 6-inch nail in his boot. He was close to passing out. It was painful. They didn't know what they were going to do with him. He was wrenching in pain. And the patient had to be sedated with very powerful opioids. When they removed his boot, they looked at his foot, and it turned out that the nail had passed clean between the toes. There was no injury whatsoever. Pain is fascinating because it sits at the intersection of biology and psychology, and it reveals how those two are intertwined. How pain works is complicated, involving nerve endings in the body. Katie talked about that. She showed us some diagrams of that, and you all know that in your professions. Many regions of the brain and an additional nerve pathway from the brain back down to the body. There are inflammatory chemicals in the body that can enhance or diminish the experience of pain. And those who are in the medical field, like you, can explain it much better than me, who's in with the brain. We can imagine our pain system is like an alarm system on your car. Again, Katie and Dr. Anna both alluded to this. I was afraid they were going to steal my thunder on this one. I came up with this. The alarm system on your car can break. So our body, think about it as like your alarm system. We've all been there. We've all heard car alarms going off while the owner is standing outside the car trying to turn it off. It can also go off when someone accidentally just brushes up against the door, when that alarm is really meant to just sound when someone is breaking into your car. Our pain in our bodies is something like that. It may start off as an acute injury that never goes away. It can also be the result of nerve problems, degenerative diseases, and there's some evidence that differences in brain structure can predict how we handle our pain. Our thoughts, our personalities, and our learned behaviors can influence whether our alarm gets tripped. So do our emotions. If you get an on-the-job injury and you hate your job, you're more likely to become disabled by the pain. I think we've known folks like that. Physical problems in the body don't always create pain in our minds for reasons that scientists just don't quite understand yet. It's not that the biological, anatomic reasons are not important. They are just a part of the picture. You've all seen that before, that pain scale. Okay, we have people that come to us that talk about pain. They talk about their pain. I'm a 10. I am a 10. I am hurting so bad. And then you start talking to them, and I know you all do this too. You start talking to them about their pain. Well, how bad is that pain? Tell me about your pain. Exactly how bad is it? You guys can see that up there. I can't really see it on my little thing. But if you see the big red one over there, and he's crying and he's grimacing, underneath that 10, it's called unimaginable and unspeakable. Now, we do not share this with folks that we're trying to help them cognitively, because if you share that with them, they think, I can get to that level if I'm not there yet. I don't want to go back to work tomorrow. And then we have the little green guy over here, and he is no pain. And that's the one that I always showed my kids when I was working with them. They would come in, and some of them would have suffered some pretty violent things going on in their families. And you know, you always show the happy guy, and you show the sad guy, and I always show the happy guy. And talk about, are you close to this? Where are you in this? And then they recognize with the smile. They recognize with the happy part. This is all in our, it's our minds. It's how we wrap ourselves around what's going on with us. So we do not use that, but I know some people that still use that, and I grimace when people come in and tell me, well, I saw the pain scale and I'm a 10, I think I'm an 11. So that is that catastrophizing pain.
I'm always like, okay, let's call the ambulance. If you're a 10, then you have to, we're calling an ambulance right now.
Exactly.
Lay down, you know, That's, we're
Exactly.
taking it to the emergency room. They're like, wait, no, maybe I'm
Yeah,
not
wait,
that bad.
hold it, scale it back a little. Maybe I'm not a 10. Let's talk about a 10.
Oh
But
gosh,
you know,
you're a 10. That's
yeah, and you know, even those words, those explanations of what they are. Like number 5 says, very distressing. Well, when I say very distressing, in my world and my vocabulary and my thought process, might not even be a 5 to me. Very distressing for me is totally something different for you. For example, I was talking to a nurse at Carbondale one day this week, and he came, he's very tall and lanky, and he came walking in and limping, and I said, I didn't realize, you had something going on. And he said, yeah. I said, well, what is it? He said, well, my pain level's about a 5. And I said, okay, well, what's a 5 to you? And he said, well, my 5 is different than the people that I work on, because my 5, I think, is probably excruciating. Some people would call it a 10. He's going to have surgery next week, so I'm thinking that his 5 is probably more up there. But he can wrap his mind around his pain. He knows that it's there. He knows he's going to walk on his foot and his leg all day long, and he learns how to compensate for that. Pain isn't something that is just happening to us. We are participating with the pain by how much attention we give to it, by the contents of our thoughts and of our appraisal. How awful and negative is it? I actually worked with some behavioral health therapists before that actually asked these questions. How helpless and hopeless do you feel about it? Do you feel like a victim? Do you feel at the mercy of your pain? I go totally opposite of that. I talk about, how are we feeling today? How can we feel better today? Tell me a little bit about what you were able to do this morning. Did you get up? Did you get out of bed? Did you make your bed? Did you have to use a walker today? Maybe not. Maybe they just used a little cane today. So you try to look at it more positively. My friend that I was telling you about had been catastrophizing his pain, thinking of the worst possible outcomes, like losing his job or having to largely start over in life. By the way, he owns his business too, so it's a big problem for him. A similar thing happens to people who suffer from anxiety. Feelings get magnified in a loop of negative rumination. Research has shown that catastrophizing is associated with worse pain outcomes, more intense pain, and a greater likelihood to develop the chronic pain. Neuroimaging studies suggest that if you engage in catastrophizing thoughts, it amplifies the pain process, so you're unwittingly pouring gasoline on the fire. One of the most terrifying things is not knowing what is wrong. You see, I've got fear of not knowing what is wrong. We've all been there. The person with pain goes from doctor to doctor who try to fix the pain. We feel this pain and we wonder if it's just going to get worse. And so we've turned to opioids, which we're now trying to turn away from. Opioids, as we found out, might reduce the pain, but then you find that you're still experiencing the pain, and because of the way we approach pain, the way we think about pain, and the way we allow it to affect our lives, we have the thought process that we should never experience pain, and that, as we all know, is not true at all. Well, this is where the cognitive behavioral therapy can help. So why behavioral health? Our role as behavioral health therapists in this whole group is to help the patient find ways to cope better with the pain, as well as to reduce the negative impact pain has on the patient's life. Our focus is not on finding a cure or a fix, but on giving the patient more tools to manage the pain so that they can improve their quality of life. Now, this was the development of cognitive behavioral therapy, chronic pain. They call it CBT-CP. The CBT-CP model developed in part out of the success of CBT for depression and anxiety. I'm sure that you've seen patients come in and they're dealing with pain, they're trying to get themselves fixed, and you see them kind of loop into depression and have anxiety. CBT-CP also developed out of the multidimensional models of pain, and we've talked about already, and I'll skip that slide in a minute, biopsychosocial model that emphasizes cognitive and emotional factors. CBT is a form of talk therapy, in case you don't know. I talk a lot. That helps people identify and develop skills to change their negative thoughts and their behaviors. CBT says that individuals, not the outside situations and events, create their own experiences with the pain included. And by changing their negative thoughts and behaviors, people can change their awareness of pain and develop better coping skills, even if the actual pain level stays the same, which we know sometimes it will. We're learning how to deal with it. The perception of pain is in our brains, as we've already talked about earlier. So you can affect your physical pain by addressing your thoughts and your behaviors that fuel it. So we kind of looked at this also this morning. So every time Katie pulled something up, we talked about it. Well, we're talking about the same things. So luckily I had a little bit different one up here. But you see that loop that's going on. You see you've got the chronic pain. You've got the thoughts, catastrophizing, negative beliefs. Then you go on to your emotions, depression, you're angry, you're not getting better. Anxiety builds up. Your behaviors, you begin to avoid things, you begin to withdraw because you can't do things that you did before, and you see that it loops around. CBT can also change the physical response in the brain that makes pain worse. Pain causes stress, and stress affects pain control chemicals in our brain. CBT reduces the arousal that affects these chemicals. This, in effect, may make the body's natural pain mechanism more powerful. It encourages a problem-solving attitude. To take action, you feel more in control. It involves homework, just as Dr. Anna and Katie talked about earlier, keeping track. And with folks, when they come to us, we have them journal. We talk about your thoughts and your feelings associated with the pain that you're having. What were you doing when you had that pain? You know, were you sitting down, were you eating supper with someone and somebody said something that irritated you and suddenly your pain level went up? It's just thinking through, writing it down, looking at it later. Why did I experience more pain today doing the very same thing I did yesterday? What was different? It's just using the brain to alter your thoughts and your feelings associated with that pain. We do those assignments every week with our patients, and then we have them come back and we have them share from their journal. And we let them talk about, put it out in words about what's going on. What are you feeling? What happened this week? Why was life different this week? Why are you experiencing more fear, more anxiety? Has your pain level actually gotten worse? Do we need to refer you back? Do we need to talk to your physician again? This also, by the journaling and doing these different life skills, it gives the patients ownership themselves. They feel like now that they have some control over that pain that is going on. It's not just up to you to fix it for them. They suddenly feel that they take some ownership in it. Here's some of the immediate targets for CBT-CP. It's to reduce the impact pain has on daily life, learn skills for coping better with your pain, improve physical functioning and decrease intensity of physical pain sensations and frequency flare-ups, to maximize daily function and improve your quality of life, minimize reliance on pain medication, and that's really what we're working toward. I was so happy to get involved in this group because we work a lot in behavioral health with people who are addicted to opioids. So we constantly see them and we send them to either day treatment, or some people need inpatient therapy to get off of the chemical. Sometimes they need MAT treatment, but you can't do those pieces without involving your brain and your thought process. That's what we've left out before. We've left out that piece, and the medical field has done that for years, but we're finally coming around to realize this is a whole being. It's not just my body, it's just not my physical part, but it's also my thought process that's going on here. So we also want to decrease that negative thinking and painful emotions, and what we've all talked about this morning, the anger, the anxiety, and the depression. So back onto what my therapists do when they will get these patients. They will have weekly sessions, and I think Dr. Anna talked about the goal is probably 11 sessions. The pain is evaluated. Now we are just on our level looking at what was referred to us from the physician. And then we look at that with the patient and we talk about it. So we evaluate it and we discuss the current pain management methods. What are you doing? You going to OT? You going to, where are you going? What are you doing? Are you showing up? Are you showing up for your appointments? And if you're there, are you on your phone the whole time? Are you engaged? What's your thought processes? What's going on? Are you making it hard for your therapist? Or are you engaging in part of your self-care? So how to get the most out of CBT is, number one, believe that it will work. Number two is they must actively participate. Number three is we make sure that they complete their homework. It's just as if they were children and they're coming home from school and they've got homework to do. It's very important to do the homework. Very important for them to practice the new skills. And with us, it's the cognition. It's thinking about, how do I retrain my brain? Now I'm going to walk the mall. I haven't done that in some time because it just gives me so much pain. How am I going to do that? How am I going to wrap my brain around that? Well, we give them thought process skills to do that. Okay, just walk from point A to point B. That's all you have to do today. We break it down into little sequences. We help them look at their thought process to see if there's an alternative way of looking at things that might be a better way and might help them. And here we are on that chronic pain cycle again. There's a cost to chronic pain. The cost of the inactivity, which you all see patients like that, more pain, poor physical fitness, less time with family and friends, depressed mood, or increased irritability. My friend really had increased irritability. Actually, they ended up having to go to marriage counseling because she just couldn't understand where all of his irritability was coming from. And honestly, he couldn't understand it either. He didn't realize that focusing on his pain, which honestly was probably about a 2 or a 3, but focusing on his pain was causing amplified problems in his family life and even with his friends. He had depressed mood and his increased irritability. He had lower self-esteem because he was not able to get out there and do what he had always done before, his manly things that he was doing. Increased strains on relationships and decreased quality of life. There were some days that he called me and he had not been out of bed, and it was like 2 o'clock. So let's look at this again. There's that cycle again. For those with chronic pain, the role of negative cognitions can be powerful. As pain persists over time, the patient's thoughts may become more negative and exert a greater influence on their pain. Oftentimes, negative thoughts are automatic and outside of one's awareness, but may still significantly impact their emotions and their behaviors. And this is what I've talked about. sometimes we don't realize that the way that we are looking at things causes us to respond differently. Just like if somebody comes to you, the whole gossip thing, if somebody comes to you and you see them every day and they're gossiping and they're talking about somebody and that goes on, and it's not long that you find yourself repeating that to somebody else. And then you realize, wait a minute, I don't like doing that, that is not me, so I'm going to remove myself from that situation and that thought process because I want to be a positive person. I want to see the good in everybody. Well, this is the same way with our pain. If we focus on that pain and we say that that's us, that pain defines me, then that will define you. You will find yourself in bed not being able to do what you did before, and quality of life goes down. So our thoughts and pain. So we have increased stress or negative emotion, and I said the therapist will discuss with the patient those negative thoughts. The patient will often recognize that with increased stress or negative emotions, they have an increase in pain intensity. They will also likely recognize that increased pain brings increased negative thoughts that I've just talked about. While the patients may be able to easily identify experiencing emotions such as frustration or sadness, the therapist will discuss that the negative thoughts often accompany these feelings and may be precursors. For example, waiting for an extended time at a doctor's office. What does that do to us? It brings on feelings of irritability and impatience. I'm proud to say we're doing things about that at SIH. We don't have to wait anymore. But that's what it does. And so what are the thoughts? I hate waiting. This person is always late. My pain is getting worse the longer I sit here. We've heard patients say that, I know. Challenging the automatic negative thoughts, what we call the ants. And I put a little snippet of one of the little forms that we use. The therapist will have the patient identify a day and a situation when they had a negative experience, preferably pain-related. And so we add that to the day situation column that you see up there. We consider the ant they had at this time. And we add the identifying ant to the column. Was the ant helpful or harmful? This is just another way to pull our brain in, to get our thinking around writing it down. Here it is. I can see it. If you see it, you can see it, you can tell that, oh my goodness, that is how I felt that day. This is what my thought process was. So we found that to be very helpful. Once you notice an ant, we pause to consider the cognition. We challenge the negative thought by trying to collect the facts. So we ask questions such as, is this 100% true? And you can do this with yourselves, with other things other than pain too. Is there a different way to look at the issue? What would I tell a close friend if they had this thought? And that seemed to be very opening for some of our patients that we work with. When it's not just focused on them, but they can think of a best friend and say, well, what would I tell my best friend if they had that thought? Is the thought helpful to me? Is there evidence that I am not taking into account? When you answer these questions, you have a more balanced and realistic view of the situation. Replacing the unhealthy thoughts with more accurate ones will help you cope better and allow you to practice more effective in your pain management. So, some coping statements. Another technique that is helpful in managing pain flare-ups or negative thoughts or mood is the use of coping statements. This helps the patient remain calm during stressful situations. It's a go-to phrase that can replace unhealthy thoughts. It can help patients cope with specific, difficult situations, especially ones that may be unanticipated. So there's a list of positive coping self-statements, like one step at a time. I can handle it. I just have to remain focused on the positives. It will be over soon. I can control the pain. The pain does not control me. It won't last much longer. This isn't as bad as I thought. No matter how bad it gets, I can do this. So here's a coping statement, a piece of a coping statement checklist that we use with our patients. So we get it down there again on paper, let them see it. Sometimes it's better just than it's the thinking stage. You put it down here and you can see it. So we ask them to use this checklist. The pain flare passes in a while. Can they own that? Can they put a check mark there? Can they put a check mark on I can handle this? I just have to make it through this moment. I've gotten through it before and I can get through it again. I don't have to suffer. I now have skills I can use to cope. Now what would I tell my friend if they were in the same kind of pain? After several sessions with the therapist, she or he will highlight the patient's progress with the patient. And they'll talk about this. Have you become more active? Has your mood improved? Do you feel like your life is more fulfilling, even though you still have your pain? Are you accomplishing more? Have you noticed a difference in your pain intensity? What about how you're reacting to your pain? So we go over that, and we kind of make markers to see where is the patient. Is the patient getting better? Are they learning how to deal a little bit better with their pain? So then discussing obstacles and barriers. A combination of rehab, CBT, and other modalities helped my friend get back to work, but there was still some pain there. Even though the medical professional could not find an underlying physical reason why, he now understands that his pain is caused by central sensitization, or his broken pain system. After CBT, it's not a cure-all. The pain doesn't seem to have lessened, he said, like on a 1 to 10 scale, but the amount of suffering that goes along with it is less, he said. He's realizing now he can work again. He can concentrate on helping his kids with their activities now. His sense of humor has actually returned. He stopped worrying so much about the future. Though the pain is still there, he's paying less attention to it with his learned coping skills. This is different from the relief that he got from the opioids that he was on. And it was really hard to see my friend go through that. He got so bad that he was calling around with some of his friends that when he would run out of his prescription, and this is a guy that, he's just an outstanding community member. He got to where he was calling some friends who he knew had maybe had some dental work done that might have an opioid there, or even called a grandma that he knew of that she had had a little bit of surgery done and they loaded her up with a lot of pain pills and he knew about it. He was calling around trying to get those, and he called me one evening, and so we started talking about it, and that's when he got to the realization that, wait a minute, people think that because the opioids are prescribed by their physician that they won't get addicted or they're not a user. But we fall into that. We don't do it on purpose. It just happened to him. So he went to some intensive inpatient treatment. And then after that, he kind of fell back a little, and he does therapy with a CADC person. So they talk a lot about not using the opioids. And so along with our CBT, he has really gotten his quality of life back. In the brain, emotional pain and physical pain interact, and we've been talking about that all morning. Just as people sometimes turn to opioids to mask their emotional problems, psychological therapy can help physical pain. It's time now that we all recognize that there is so much overlap that we almost can't treat one without addressing the other. And there are my references. Have any questions? Are you all convinced now? That was my job today, is to convince you. One other little caveat I want to say is that, you know, when people try therapists, behavioral health therapists, there's all kinds of them out there that have had all kinds of education or lack thereof. So if you send somebody to a behavioral health therapist and you feel like it's not working, it's okay to ask to change to somebody else. Sometimes you just don't hit it off with that person. We have children that do that with some of our behavioral health therapists. I've got 2 young therapists out at CMA, and they're both delightful. But we had one little guy who's on the autism spectrum, and he decided that he didn't like the one therapist. It hurt her feelings, but you know, we talked through that. But later we were able to talk to Mom, and he was relating what that therapist looked like. She has blonde hair, she's really pretty, and she wears decorative pants all the time. The kids love it. She reminded him of a foster parent that he had that had been very mean to him. So there are reasons sometimes. It's not going to hurt our feelings. We'll get over it. If we don't match with you or your patient, it's okay to ask for a different therapist. What we want to do is help the patient help themselves be healthier. Thank you.
Sherri, I just have a quick question about, we have resources, maybe not within your program, but within the region, that if we start to work with someone and we figure out, and your people are going to figure that out as well, and we see that addiction is, that we are addicted and we need to address the addiction as well as all the other things that we're doing, we do have some resources around the community that we can, that your people will help us refer to.
That's a very good question, and I think that, you know, we will find many of your patients that are addicted to their opioids. I know I talked to Dr. Burchell and Daryl like a year ago. You know, we were talking about all this, and I was so excited because we have a large number of people in our region that are addicted to opioids, and it's a major problem. Something that in behavioral health we work on every day. But yes, I have some therapists that are not only licensed clinical social workers, but they're also CADC, so they're trained in working with people that have substance use disorders. We are all trained on recognizing the signs and symptoms and recognizing people that are drug seeking. We're getting better about it in the emergency departments also. You know, sometimes I'll look at the emergency room board and there will be somebody in there for a toothache, and I immediately call my therapist that's there, you know, and alert them there's somebody there that's in the emergency department. It's a Monday and they've come to the emergency department for a toothache, when we know that they have a dentist that they could go to. So, you know, the yellow flag goes up for us, and we begin to watch that patient just to make sure, and of course the physicians do too. But yes, we refer out to Gateway. We do that a lot. Gateway is a good partner with us. They're in Carbondale. They're also up in Alton. They're in different areas. We also have down in the Union County area, we've got inpatient down there. The name of it's leaving me right now. Yeah. Uh-huh. Yes, exactly. So there's a lot of resources, and even, we haven't talked about case management here today because that's Sue Nordstrom's piece of it, but even inpatient, some of those case managers are cognizant of, you know, when they see a patient that they go, you know, there might be some drug abuse here, and the physician talks to them about it. They'll also refer out. So we try to all work together so that we're making sure that the patient gets where they need to be. Clearly, if they come to us and we can work with them cognitively, but if they've got the opioid addiction, they need to go someplace to learn how to wean off of that. So that's why we're doing this multidisciplinary approach. Yes?
Do we have to options available to us, and how do we know the difference?
Okay, that's a really good question. Right now, Dr. Anna is the one that's going to be flagging the patients for us, and we'll be sending them to a couple of our LCSWs. Again, as Verlinda said, this is in the pilot stage. So right now, we're using a couple of our LCSWs that are in one of our other clinics, and we're going to see, how this gears up, and then we're hoping the plan is to hire some more. Right now at SIH, we do not have a psychologist, although I've got one that I'm looking at that's very interested in this. I just have to make the plan and the pitch, to the VPs. So that we can do that, but they're very interested in this also. So for right now, Dr. Anna is the one that will be referring, so you don't have to worry about that. But for sure, if you're seeing something in your patient, let them all know, and put a flag on it, let them know, and then she can take an extra look at that and then refer if needed. Very good question. Yes?
There's such a stigma around mental health with the patient population that we see. Do you have any strategies or suggestions for us as frontline when we go to mention that to the patients? Because a lot of times people get offended. They're like, oh, you think I'm crazy. They say things like that. So any strategies that you can provide us with would be very helpful.
So that's a very good point. There's still a lot of stigma around mental and behavioral health. It happens here, it happens all the time. And we are really working hard to break down that wall. So if you have a patient and you're detecting that, there's some extra depression there, or maybe that patient is not showing up for their appointments, or when they do show up, they're just not engaged at all. They might even share with you that someone close to them has passed, those type of things. Then you can just say, we have people here now at SIH that can help you with that. This is why we've placed the LCSWs in the clinics. So they're not going to go to some outside building that says behavioral health. We're not going to do that, because then people think, oh, they're watching me go in, they think there's something wrong with me, I'm not crazy, as some people say. But that's how you do it. You just do it gently and say they are therapists. If you call them therapists, but then you have to differentiate that they're a behavioral health therapist, because we're clearly not your kind of therapist. And people are more, we have found that people are more open to it. Yes?
I heard something on the radio that really stuck with me. It's just help people realize that loss is normal. And sometimes people need just everyday people, maybe they're not overly depressed or diagnosed with bipolar or something, but they need a little help coping with the losses in their life.
Right.
And if we can help them realize, this is normal. It's
Right.
not negative, it's not bad, that you might just need somebody to talk to help you realize that this chronic illness is a loss.
Right.
You've lost the way you wanted your life to be. Maybe you've lost the ability to do things the way you used to be. So it's a normal loss, and you can help them realize
Exactly.
somebody there to help them through those coping strategies would help them in their pain as well.
Exactly. And that's what I tell a lot of patients is, life might not be like it was before, but now we're going to work toward a new normal. This is going to be a new normal. It's going to be good. It might be different, but it's going to be good. Life is not over. Right. Very good point. Any other questions? Okay.
Thanks, Sherri.
Thank you.
We had set up to do a round table, but since you guys have asked all your questions individually, we're going to do something else, because this is the first time that we've had a multidisciplinary group